Welcome. I'm Ramesh Tripathi, Associate Professor at University of Queensland, Australia, and I'm also an Adjunct Professor at the University of Sunshine Coast. I'd like to welcome you today to an interesting webinar on recent developments for the treatment of acute and chronic venous outflow obstruction. Today's program is brought to you by Radcliffe Vascular. It's my pleasure to be joined today from Germany by Dr. Michael Lichtenberg. Michael is an interventional angiologist from Arnsberg Vascular Center, Germany, a well-known figure in the treatment of iliac vein obstructions. Before we start the program today, I'd like to remind you that this is an interactive session and we welcome your questions. Should you have any questions for myself or Michael, please submit them in the form below the live stream on the web page, and we will try to address as many as possible in the later part of today's session. I'm very pleased to have Michael with me today, and we'll start off with Michael's presentation on acute obstructions of the iliac system. Michael.
Thank you very much, Ramesh. It's a pleasure and an honor to be here today, and I'm really looking forward to a very interactive session on this very interesting topic on acute and chronic venous outflow obstruction. Great that so many participants are here today, and this really shows that this is a very intensively discussed topic because we can really help patients suffering from acute and chronic outflow obstruction. Let us first start with an acute treatment of acute iliophomal DVT. I would like to give you an overview of the recent publication and studies on especially mechanical thrombectomy. I would like to answer if mechanical thrombectomy might be the future and not still the still used thrombolysis therapy. My conflict of interest and my disclosures you can find here. In general, of course, it is clear that the post-thrombotic syndrome after iliophomal DVT is quite frequent, but unfortunately still underestimated as a chronic complication. More than 25% of the patients are at risk for developing a post-thrombotic syndrome following an acute iliophomal DVT. The recently published ATTRACT trial even showed a frequency of 28%. And of these patients, up to 10% even develop a severe post-thrombotic syndrome. So there's a clear need to help these patients who are showing up with an acute iliophomal DVT. We all remember the initial ATTRACT trial, and we learned that treatment of FEMPOP DVT is definitely not the way to go. But unfortunately, the initial ATTRACT trial also showed us that there is not a significant improvement for an acute treatment of patients with acute DVT. The followed ATTRACT subgroup analysis, just dealing with the patients with acute iliofemoral DVT, showed us that it is really a helpful therapy to treat patients with acute iliofemoral DVT. And the statement of this ATTRACT subgroup analysis, which was published by Komorota, clearly stated these findings support early use of a percutaneous thrombectomy approach. When we are looking at these data, and especially also on the clinical outcome data of the subgroup ATTRACT trial analysis, we can clearly see that patient in terms of the specific vein score improved significantly over the patients who just received a conservative treatment. And this was a clear sign and a clear hint and a clear proof that patients with acute iliophomal DVT should be treated with an aggressive thrombectomy approach. This was also then within further analysis of the subgroup analysis of the ATTRACT trial, then proven by Susan Kahn who definitely analyzed veins QL and the SF36 change scores within the ATTRACT subgroup patients, and clearly stated again that the patients from baseline to full assessment during the follow-up improved in terms of their symptoms after iliofemoral DVT. And all these analyses clearly stated post-thrombotic syndrome could be avoided with an aggressive thrombectomy approach. Here you see the veins QL change scores within different subgroups, and you can clearly see that all subgroups improved. Regardless of age, sex, and race, patients with an acute iliofemoral DVT improved with an aggressive thrombectomy approach. But we shouldn't talk about only efficacy. We should also, of course, talk about safety, because the still used thrombolysis therapy, which is still the standard technique of thrombectomy or treating patients with acute iliofemoral DVT, of course, has the problem with bleeding complications. And when we are looking at older studies like the Pearl Registry, Venous Registry, Carvin trial, which were published in the 90s or the beginnings of this century, we can see that there were a lot of bleeding complications reported because of thrombolysis. And that means we need to discuss about safety also. And therefore, we performed also recently a systemic review, a meta-analysis on this term, and to find out if thrombolysis versus a pure mechanical thrombectomy approach maybe show a better safety outcome for a percutaneous mechanical thrombectomy approach instead of using thrombolysis. And this meta-analysis, which we recently published in the VASA journal in Europe, clearly stated that the bleeding complication was significantly higher with a thrombolysis approach, with a CDT approach, than with a percutaneous mechanical thrombectomy approach. And we clearly stated within this meta-analysis comparing thrombolysis versus percutaneous mechanical thrombectomy that thrombolysis is, of course, efficient, but not very safe because of the bleeding complications, and that we should consider percutaneous mechanical thrombectomy approach maybe as the future treatment or as the best treatment for patients suffering from acute iliofemoral DVT. But of course, we need to answer if all the devices which are on the market are really efficient to treat iliofemoral DVT. Here are some of these devices which I would like to show you. You may be familiar with that. The Indigo device, the Aspirex device, the Angiovac device, especially for IVC thrombectomy, the Indigo Aspirex device for iliofemoral DVT. There are now also more modern systems, which I would like to show you in a second. But let me first summarize on the existing data for these mechanical thrombectomy devices which I just showed you. And the first one I would like to show is the data on the Aspirex device, the mechanical thrombectomy device from Straub Medical, now by BD Bart. We analyzed within our Arnsberg registry the efficacy and safety of this Aspirex device. And what we found out in 56 patients within this trial, these patients showed up with acute iliofemoral or descending iliofemoral DVT, that the usage of the Aspirex catheter, usually the 10 French Aspirex catheter, was very efficient in treating patients with acute iliofemoral DVT. We had a technical success rate of close to 100%. And what you can see here is the patency analysis after effective thrombectomy and treatment with a dedicated venous stent. You can see that the patency rate after 12 months in our cohort was 87%. So we could show within this registry the safety, the efficacy of this device, but also showed that the concept of a mechanical thrombectomy approach and then stenting of the underlying reason of a May-Thurner syndrome, for example, is efficient and safe. There's also another trial organized by the company itself. It's called the Pmax Study. And they allowed us to show some of our Arnsberg patients, which we included in this trial. We included 24 patients in this trial. And what these 24 patients also showed, they showed the same as in our Arnsberg registry, that this combination therapy of a mechanical thrombectomy approach using the Asperg's catheter together with a venous stent implantation was very efficient. Here, as you can see, in terms of freedom from clinical-driven TLR, after 24 months, we have freedom from clinical-driven re-intervention of close to 94%. So a very efficient therapy also in long term. The patient improved. As you can see here, the VCSS score improved, the VDSS score improved over time. So also these objective data showed the clear improvement of the patients. Also for the Indigo system from Penumbra, which is also a mechanical thrombectomy device, there are some initial data now available, some small single center experience. In general, this device here uses a little bit of different kind of technique. The Asperg's catheter uses the system of Archimedes principle. With the Indigo system, you use a vacuum with close to 737 mmHg to suck out the fresh thrombus, as you can see here with the machines and a dedicated 8 French catheter. There are initial reports as stated for this device here. This is a summary of the so far reported patients within a single center. This is the largest cohort analysis. They showed a technical success of 60%, which is definitely not that much, but showed that the concept of this mechanical thrombectomy also works quite well. This is a typical case example. One of the patients we treated recently, a young lady showed up in the emergency department in the morning with a severe swollen leg. And what you can see here on the angio, which we performed after a transporpetal approach in prone position, an acute DVT here with fresh thrombi within the iliofemoral system. And after using the Asperg's mechanical thrombectomy device here, we could suck out the fresh thrombus. This is the angio after 2 passages, and clearly could find the underlying reason, which was a May-Thurner syndrome with a chronic obstruction within the common iliac vein. And then we definitely, after successful thrombectomy, performed an IVUS-guided stent implantation. And within one therapy approach, so within one session, we could treat this acute DVT and send the patient home the next day. There are more and very efficient systems are now coming to the market. This is a very interesting device from VTEX Medical. They're close to CE mark. This is a 2-in-1 system. It's a system which has a 90-needle cage which you can deploy at the tip of the catheter. And within the catheter, you also have an Archimedes screw which rotates. And with this 90-needle cage, which you can see here, you can detach fresh thrombus from the vessel wall, and with the Archimedes screw within the catheter, you can suck out the thrombus after detaching. And this system here was used in one of the first in men patients here in my center. You can see here an occlusion, fresh occlusion of the common femoral vein on the right side here. And we use this device here. You can see here after deployment of the cage proximal and activating the rotating Archimedes screw, we were able to detach the thrombi from the vessel wall and immediately sucked it out. And after using this device, you can see here a very good outcome in terms of opening the vessel and flow with a very good outcome immediately after the usage of this device. This is a second example from Gary O'Sullivan, who is also participating in the first in man trial. He was treating here an acute full iliofemoral DVT and also used this device in the femoral porpetal vein. You see here the opening of that cage and the activation of the Archimedes screw. And he also had a very great outcome here after thrombectomy. And you can see here the May-Thurner syndrome in a common iliac vein, which he then stented and also had a perfect outcome after this combination therapy. The study itself, which will soon lead to CE mark, analyzes safety and efficacy of patients. Just want to briefly mention that we included in this trial so far 16 patients, and these patients improved significantly from baseline in terms of half circumference, veins QL, Vialta score, and VCSS during follow-up. There were no safety issue, no bleeding complication, of course, because no additional lysis was necessary, so a very efficient device. Another very interesting device is the clot retriever mechanical thrombectomy device, which you can see here, which was recently brought also to Europe. And so far, there are some initial experience with this device. The principle of the device is that you open a kind of nitinol cage above the thrombi and then take within this nitinol tent everything out. So it's captured within this tent, and you can take out the full thrombi in one step approach. Very interesting device. Another very interesting device is the Jedi Device, which works a little bit like the devices, the AngioJet device you can see here, using vortex principle. It sucks out the thrombus and can even suck out chewing gum here, which we used here in this bench test. Very aggressive and very efficient device for acute DVT treatment. There's some initial reports also for this Jedi device here, as you can see here in JVR 2019 reported, and they reported a very good efficiency and safety for this device without any safety concerns. Unfortunately, no more data so far available. This is a typical case which we actually did yesterday, so sorry, these are the raw data. I was not able yet to really make some nice pictures out of that. Young ladies, 17 years old with an acute DVT, we performed here pure mechanical thrombectomy and stent implantation because of a severe destroyed iliofemoral tract. And today we sent the patient home with this one-step approach within one session. So let me conclude for this first part. The real advantages for a percutaneous mechanical thrombectomy is safety, because you don't need any additional thrombolysis. With that, you have significantly lower bleeding complications. And we could show also within our meta-analysis, which I briefly introduced you to, a trend to a lower pulmonary embolism even with the PMT devices. PMT and CDT, based on the meta-analysis which we published, are quite similar in efficacy. There's a trend towards lower overall PTS and reflux with PMT, but definitely not significant. But my statement is clear. The thrombolysis therapy, a catheter thrombolysis therapy, from my perspective, should be stopped because we have now very efficient percutaneous mechanical thrombectomy devices with which we can definitely lower the amount of thrombolytic therapy or can even avoid thrombolysis. Thank you very much.
So that was a great overview of what is available at the moment and what is the some of the evidence for use in acute DVT of mechanical thrombolytic devices, thrombolytic devices, so or thrombectomy devices, so as to speak. One of the questions that has emerged from the audience is that is percutaneous mechanical thrombectomy easy to do, or is proctoring required for that? And you take the question first, and then I'll put in a few comments. Yeah,
I think that's a very important and a very good question. You know, all these devices need a kind of training. Thrombectomy within the venous system is not as easy as in the arterial system because you're dealing with fresh and organized material. Usually, these patients are showing up after 1-2 weeks or a couple of days after having symptoms, swollen leg, and this makes it sometimes quite difficult to really perform an effective thrombectomy. And it's sometimes also very difficult to answer the questions how to assess the acute DVT. Do we use a transpopliteal approach, or do we even need a transtibial approach? Do we need a transjugular approach? How can we be effective? So I definitely would suggest someone who would like to start with thrombectomy, and especially mechanical thrombectomy, should use the help of a proctor to really achieve a very good outcome for the patient.
And the other question I wanted to ask is, you said that these newer devices of mechanical thrombectomy have got maybe have a role in femoral popliteal DVT. I know that in the iliac system there are no valves, and in the femoral popliteal system there are valves, and there are consequences of valve damage during mechanical thrombectomy and subsequent reflux problems. Do you think that there is a different kind of device that is needed for femoral popliteal, or you think adding thrombolysis and thrombectomy together, or some other methods to empty the valve pockets, perhaps ultrasonic may be the future?
Yeah, probably. But let me clearly state, a patient with acute FEMPOP DVT is definitely not a good candidate for thrombectomy or thrombolysis. Based on literature, especially based on the experience with the TRACK trial, we definitely need to state FEMPOP DVT has no indication for aggressive treatment. Of course, we are treating FEMPOP DVT if we have an iliofemoral DVT. Then on the way up from a transpopliteal approach, we also approach the thrombus within the FEMPOP area. This is clear. I definitely would like to support what you said. This combination therapy might be a very good option, especially in the FEMPOP area, to empty the valves, the residual thrombosis, which could be a problem for the inflow, especially to the iliac system. The data are not very conclusive so far. Based on our experience, I must say that some of the devices, like the VTEX device with this cage at the tip and the Archimedes screw within the catheter, seems to be also very effective in the FEMPOP area. And we could even with this device clean up the FEMPOP area. So far, and we looked at this, we did not see a damage of the vessel of the valves, but definitely this has to be analyzed for every device. Of course, we don't want to have a significant valve insufficiency left behind, and definitely this should be one of the endpoints within these trials.
Which is your favorite PMT device? Go-to PMT. How do you choose your device?
Yeah, that's the difficult question. Yeah, we have so many devices now available. So it really depends on the age of the thrombus. So if I have a little bit older thrombi to be expected in the system because of symptoms for a couple of days, I probably would use the Esprex device or the VTEX device. Fresher thrombus, I would suggest to use AngioJet or the Jedi system. They can really perfectly deal with these fresh thrombi. So it really deals with the age of the thrombus.
And, up to what age of the thrombus would you attempt to do this? Classical teaching is 2 weeks. Yeah. Do you think with these devices you can extend that period?
I wouldn't be too open by this time. I think we should definitely be very objective to analyze these devices and stick to our experience and not treat patients who have symptoms longer than 2 weeks. This would be my personal opinion. Of course, there are some patients who have a lot of symptoms even after 3 weeks of conservative treatment. So there might be the individual patient indication in some of these patients, but I would not go as a standard approach a patient who are suffering more than 2 weeks from the DVT.
That's great, Michael. I think, and also I think we have answered most of the questions that came through from the audience. So we'll now progress to your talk on chronic iliofemoral DVT occlusions and also NIVL, and what do you do about them, and how you treat and select cases and treat the chronic iliofemoral obstructions.
Perfect. Thank you very much. Yeah, let's proceed to this because we have also very interesting data now available for the new stents, for the dedicated venous stents. So I would like to introduce you now to our approach here for treatment of chronic iliofemoral DVT patients. So what is clear, and I think we do not need to discuss much about that, the obstruction is the leading factor for the symptoms. So it's not the reflux, it's the outflow obstruction, which definitely creates the problems within the patient in terms of symptoms because of venous hypertension, which then directly leads to the symptoms of leg pain, swelling, lipodermatosclerosis, and ulceration. We learned from Dr. Neglin and Dr. Rajdu, treatment of the underlying reason of the outflow obstruction is the magic tool to treat venous ulceration. So we need to concentrate on the outflow obstruction. We shouldn't stop with our analysis, especially ultrasound analysis in the groin. We should always look for an outflow obstruction, especially in patients with recurrent ulcers, severe lipodermatosclerosis, especially after DVT, because it is important to treat these underlying outflow obstruction to help these patients. And we also learned this from their initial data also for NIVL patients. NIVL treatment is better than reflux treatment in patients suffering from varicosis or persistent swelling. So it's always a good suggestion to analyze if a patient has a significant compression of the left common iliac vein. So would definitely suggest that every patient, especially young patient with recurrent varicosis, groin pain, persistent swelling, should be analyzed for a NIVL problem. And we definitely know also from economic analysis that patients who are suffering from a non-treated outflow obstruction, suffering of post-thrombotic syndrome, are causing much more cost than patients who do not have a post-thrombotic syndrome. So there's not only a clinical indication to treat chronic outflow obstruction, there's also a clear economic indication for treatment. You can see the difference here in terms of this analysis, the economic burden of deep vein thrombosis, pulmonary embolism, post-thrombotic syndrome analysis. Patients with post-thrombotic syndrome cause a lot of impact for our systems. When we are looking at the individual symptoms of our patient, I would like to show you this very interesting analysis already published in 2004. They analyzed venous claudication and the impact of venous claudication on the individual life of a patient suffering from iliofemoral DVT. Patients with venous claudications have a significant impact in terms of their quality of life. So venous claudication is therefore, from my perspective, a clear indication for treatment, meaning patients who are showing up with venous claudication is the only symptom, in my view, has an indication for treatment of an outflow obstruction. Therefore, I would like to show you our consideration, how we approach patient and how do we decide which patient should be treated or not. So we treat patients at least with a severe C3 symptoms. Not every leg swelling with an outflow obstruction should be treated, especially if it can be managed with just some stockings. But patients with severe C3 symptoms, venous claudication, and especially patients with C4 or higher, or pain class higher than 5 on the VAS score, in my eyes, have a clear indication for stent implantation. Of course, additional indication for treatment could be very individual on every patient, like huge abdominal collaterals, atypical varicose veins, or early varicose and vein recurrence. Of course, this has to be analyzed in every patient and decided with every patient individually. Of course, the decision which patient should be treated should be made also on objective analysis. We should use all our tools which are available, and this really depends on the individual situation of every center. Of course, duplex Doppler is the standard tool to approach patients with chronic outflow obstruction. The analysis based on duplex Doppler is a must. I think this is clear. The next step is very different in terms of the individual settings. As said, within the centers, some centers prefer to do a CTV, some prefer to do an MRV. It really depends on the individual experience. Our approach is to use, after duplex and Doppler analysis, together with the clinical symptoms of patients, intravascular ultrasound as the main important diagnostic tool to decide to treat if a patient needs a stent or not. So patients who are highly symptomatic, who have a significant outflow obstruction within the iliofemoral DVT, are scheduled for an IVUS analysis, because IVUS could answer you so many individual answers, aspects within the venous system. So we then go for IVUS analysis. Of course, IVUS is still very expensive and not reimbursed in the individual system, but hopefully it will be reimbursed very soon. Next question we all need to answer is, can the patient be stented? This is absolutely important, because what we would like to have is a patency within the next 100 years. So what we definitely don't want to see are re-occluded stents. So therefore, it's important to answer some questions. We need to learn about the landing zones. We need to learn about outflow. We need to learn about inflow. We need to learn especially, do we have a good inflow from profunda vein, from femoral vein? This is so important because it really correlates with patency rate. And the flow within the profunda and femoral vein can be easily assessed. You don't need a CTV or MRV for that. But if you have a bad inflow, then definitely you need a different approach than a patient who has a patent profunda femoral vein. So these questions are very important if you schedule a patient for revascularization. Therefore, if you have a bad inflow, as shown here, the profunda is bad, or the femoral vein, or both of them show both a very bad inflow, you definitely need to have a plan B during intervention in terms of AV fistula or endophlebectomy. So you need to set up this before, because at the end of the procedure, there could be an immediate reocclusion or non-flow situation. This is definitely something you don't want to see. So definitely you should be prepared based on the analysis, on the flow analysis prior to the intervention. So therefore, sorry, this was too fast. In summary, for general approach of these patients, intervention should be considered after a thorough patient diagnosis and investigation. The decision has to be made with the patient together, based on clinical symptoms, based on objective diagnostic approach. Combines conservative treatment with invasive procedures is always important, especially in terms of anticoagulation. Stenting should be considered if patient has a lesion of more than 50%, is symptomatic, at least C3 or higher, has a good inflow and good landing zone, and a white wire can cross the lesion. I think this is the real important aspects, because if you fulfill this criteria, then you will definitely see a very happy patient during the next years, because you improved his quality of life. I think we should make a stop here and maybe take some of the questions.
Yeah, I mean, that was a very good analysis of which patients to select for iliac vein stenting, and what are the symptoms they come up with, and what are the long-term sequelae of post-thrombotic iliac vein obstruction, as well as obstruction from NIVL. One of the listeners have asked a question: how do you choose between which cases to do IVUS and which not to do? And I suppose your last line in the slide was pretty clear, that if you can pass a guide wire on which you can place an IVUS catheter, that patient would be suitable for not just diagnosis, but also stent selection and sizing of the stents. What are your thoughts about that?
Yeah, I absolutely fully agree. IVUS is definitely the way to go. Not only in NIVL patients, of course, also on the chronic obstruction patient, but in the NIVL patients, we can really analyze the common iliac vein. We can really see the obstruction. We can really see if there are web and spurs or local thrombolysis thrombosis already happened there. So IVUS is much better than a static analysis like a CTV or MLV. Depending on the quality, you sometimes can't even analyze this region on the CTV or MLV. Therefore, our approach now, since I would say 2-3 years, is a patient with symptoms who might have an obstruction in the iliac vein system is scheduled for an IVUS analysis. And if we found on IVUS analysis a significant stenosis or obstruction, we immediately go for treatment within this analysis.
Okay. So, Michael, now we can go on to the next presentation about comparing various iliac vein stents and what are their, how do you land them, and what are their different characteristics, and what are the newer stents on the horizon?
Yeah, perfect. Thank you very much. And yeah, as you said, we saw so many new stents in the last years, and therefore we should definitely talk about these stents. At least in Europe and in Germany, we have now more than 8 stents available. Actually 9. One came just to the market. I'll show you in a second. Of course, the initial one, which is used quite frequently still, is the Boston wall stent. The wall stent was then followed by the first dedicated venous stent, which was the Cook-Silva venous stent. The European experience with this stent was already presented on different congresses. And then dedicated stents like the Veneti stent within the IDE Virtus trial was in 2013 actually CE marked. And then more and more venous stents, also hybrid venous stent like the Optimate Sinus Obliquus stent, was brought to the European market. I'll show you during these next slides here about this very interesting hybrid character of the stent. And then the Bard Venovo stent came to the market a couple of years ago and already has now an FDA approval based on the vernacular trial analysis. Medtronic also brought a dedicated venous stent recently to the market, the Arbor clinical study. The 12 months data were recently presented by Steve Black this year during Charing Cross, virtual Charing Cross. And 2 years ago, a dedicated below the ligament stent was brought to the market from a German company called Plus Medica, the Blue Flow venous stent, a very interesting nitinol woven stent option for patients, especially with obstruction in the femoral vein, as show you later on. This is the latest stent which came to the market. This is the Beyond stent. I think CE mark was just applied a couple of weeks ago. This is a stent from a Bentley company, a very interesting stent with very good radial force and flexibility. We'll see how this stent definitely will have efficient and safety data during this the trial, which will start soon. Other companies are working on a new concept. Westphal Medical, US company, developed this hybrid stent. This stent will be analyzed within an FDA IDE trial, which starts soon. This is a hybrid stent with a closed cell proximal part and a flexible part distal, and also with an extension stent available to this hybrid stent. So we will see if this stent will add any value to our venous portfolio quite soon. We know about the venous stents, and we know about the conflicting design attributes of these stents. It's always a compromise of strength and flexibility, which a venous stent definitely needs to fulfill. And therefore, the statement is clear: for venous obstruction, crush resistance is absolute, but not the only argument. You also need flexibility, especially the more distally you come with the stent, especially below the ligament and in the groin. And definitely, therefore, we need to set up standards and want to have perfect outcome within our revascularization therapies. We want to have an open vessel. This is the first and important aspect of venous outflow obstruction treatment. We want to have a perfect circle. We want to have a perfect outflow. And this is what we would like to see. We want to have a circle, also called today, named as aspect ratio, an aspect ratio of 1, which IVUS could definitely show us. And this tells us that we definitely took away the obstruction within the venous system and left no obstruction behind. So the perfect circle is definitely that what we want to have at the end of venous recanalization. And therefore, this concept of aspect ratio was recently shown. And on the left side, you see the aspect ratio of 1, which definitely is something we would like to see instead of an aspect ratio of 2 or higher, because more than 2 means at the end you have an obstructed, still persistent obstruction of 50% or more. But we have clearly to state that the aspect ratio is not the only factor, but it's definitely the best factor in terms of outcome for the patient, as we can correlate the aspect ratio with clinical outcome and also in flow models like this. But the important thing is that the aspect ratio, the change in aspect ratio, correlates with the clinical improvement of patient. And this was shown by Low Kapnick in 2018 within the Virtus IDE trial. And since then, we typically use the aspect ratio as a tool based on our IVUS analysis to really predict we will have a good clinical outcome in this patient. But clearly, there's not a perfect venous stent for the whole system. We have, as I stated, a lot of venous stents now on the market: woven stent, braided stent, hybrid stent, closed cell stents, open cell stents. This means all these stents have different characteristics in terms of flexibility and radial force. And this means that we definitely need to admit that there is not a perfect venous stent for the whole system. Because proximally, usually we need high radial force. More distally, we need flexibility, kink resistant, and low fracture rate. And this is not possible to fulfill within one stent. Therefore, the statement is clear. There is not a perfect stent for the whole system. Not one stent can fulfill all these criteria. The problem is if we choose the wrong stent, like here in this patient with a typical Nivell syndrome, even that this is a dedicated venous stent, we end up with a problem. Like in this patient, after implantation of a dedicated venous stent, I don't want to name the stent, but you can see this was definitely wrong decision because the radial force of the stent was too low to really open this nivel area, and the stent was crushed and reoccluded. Therefore, we need to know about the individual characteristics of our stents, and there are interesting papers who analyzed the physical properties of the stent, like here in this Silsa publication 2 years ago, which analyzed the physical properties of the stent. And what you can see here is the difference between the stents in terms of radial resistive force, and you can see the significant difference between one stent to the other stent. So therefore, I would never ever choose a stent which has a low radial resistive force for nivel treatment, because based on this physical property analysis, I will expect a reocclusion because of a compression within the nivel area. This is something you need to know before you decide to go with a certain stent to treat an outflow obstruction. We now have a lot of trials which analyzed venous stent within the system. We have the very famous stents trials like the Virtus trial for the VC stent. We have the vernacular trial for the BART stent, or the ABRA trial. These were all recently shown. I don't want to summarize all of them. Important is all these IDE trials showed a very good safety and efficacy outcome, and therefore we can clearly state by this time all these stents are safe and very efficient. The Virtus trial, for example, showed that the VT venous stent had a very good patency rate here, as you can see here. After 12 months, primary patency rate was 84%. But beside of these IDE trials, I think it's always important to have all-comers registries available, which give us more information about the patient. And Steve Black did a great job as he analyzed his own collective in London and analyzed 2-year outcome after VT venous stent implantation in a very complex cohort of patients. And he really showed us that beside of an ideal IDE trial analysis, real world is always a little bit different, especially in terms of patency rate in patients with severe chronic outflow obstruction, meaning with involvement of common femoral vein, of bed inflow. And you can see here the primary patency rate was around 51% after 2 years. So this is the reality, actually. And this has, of course, nothing to do with the stent itself. It has something to do with the clinical symptoms and the settings of these patients. But these kind of realistic registry gives us much more ideas about the outcome of patients in our daily routine practice. Actually, I can't advance my slide. Oh, okay, now it's advancing. You see here that especially during his analysis, he described 5 stent compressions below the ligament and 3 stent fractures close or below the ligament. I will come back to this point. And he stated a little bit that the Veneti stent may be not a good option below the ligament based on this experience because of a closed cell design stent. So these kind of registry give us this information which we need to have and to really answer if a closed cell design stent, for example, is a good option for below the ligament or in the common femoral vein. We analyzed within our Arnsberg venous registry, also within an all-comers registry, the clinical outcome and the patency outcome for our patients and we found within 90 patients a very good outcome. This was a mixed cohort of patients with nivel and PTS situation. We found in terms of primary and secondary patency rate a very good outcome of 96% and 94%. Of course, patients with nivel situation have a much better patency rate than patients with PTS, as you can see here on the right side. We are now on the way to also analyze long-term data for our patients, which we reported initially in 2018. And I would like to show you the first glimpse, and this is the first presentation for our cohort in terms of long-term analysis here. And you can see here for this 90 patient, this all-comers NIVL and PTS patient group, you see a primary patency rate after 36 months of 94%. And what was very interesting was that we just have had 5 events, which happened all at the beginning of this follow-up phase. You see here these 5 events which occurred during the first 6 months. This is something very interesting because after 6 months, up to 36 months, we did not see any reocclusion or reobstruction. So that this definitely tells me personally that the first 6 months after implantation are really important, and therefore I would highly recommend to follow up patients after treatment, especially within the first 6 months, to really avoid stent restenosis or rethrombosis. We analyze, of course, also within this 36-month follow-up the patients in terms of clinical symptoms. You can see the VCSS score, patient improved from baseline to 36 months quite significantly, and this also counted for the CIP score from baseline to 36 months. The Venovo venous stent, also a very interesting self-expanding 19-node stent with the unique flared ends at both ends of the stent, which gives a very good adequate wall apposition and fixation. So this is a stent, especially for someone who would like to start with venous intervention, because it gives real safety during the implantation, as this stent would never ever move forward because of this flare end situation. Also for this stent, which is shown here, interesting data are now existing. Again, here you see the design of the stent in terms of radial force and flexibility. I think I don't want to go too deeply into that. This is the delivery system of the stent. This is the triaxial system. So we only have 2 venous stents on the market which have a triaxial delivery system. It's the Venovo stent and the Arbo stent. You see here a dual speed thumb wheel with a fast and slow deployment method of the stent, which gives you a real good feeling during the implantation, how the stent reacts within the venous system. The vernacular trial, in terms of primary patency, the IDE trial showed also a very good outcome. Primary patency rate after 12 months, 88.3%. So also very good here. Patient improved in terms of VCSS pain score, also in this IDE trial. Based on our venous registry data, I can also say that the Venovo stent is a very safe and efficient stent, and I would like to briefly summarize our experience, which we just published in the VASA journal in Europe, the 24 months outcome data, which you can see here in a mixed cohort of patients with NIVL and PTS symptoms. Also here in our cohort, we saw 3 events in terms of reobstruction or rethrombosis, but again, only within the first 6 months. No more events after the 6 months follow-up. So quite similar like in the Veneti experience within our center. You can see here also that patients improved significantly in terms of VCSS and CIP score. I don't want to go too deeply into that. Here's the CIP score. And another stent I would like to show you, which is frequently used, especially here in Germany, Switzerland, and Austria, is the sinus obliquus stent, which is a hybrid stent. And as you can see here with the oblique structure, especially for NIVL treatment, avoiding the overlap to the contralateral side, avoiding a jailing of the inflow from the contralateral side here. So when you implant this stent like here very adequately, you are not able to really harm the inflow from the contralateral side. So that's a typical bifurcation stent and not very difficult to implant. The proximal part of the stent is a closed cell part. The distal part is an open cell part. So for the flexibility of the stent, very important, this part. You see here the proximal part, the closed cell is just released, and effective treatment of the nivel area is here performed. We also performed an analysis within our Arnsberg venous registry for this stent, and also my colleague Nils Kucher from Zurich did this. This is the absolute initial report on the stent, already published a couple of time ago. And you see here these first patients, 10 patients with acute DVT, 10 patients with chronic DVT, you found a very good primary patency rate of 92% after a couple of months. And here these are our Arnsberg venous registry data. And you can see here also very good patency analysis during follow-up for this stent, and also very good clinical outcome in terms of VCSS score here, as you can see on the right side. One part I would like to cover at the end of my presentation is the story below the ligament. We are getting more and more information and evidence that stent fracture and compression below the ligament in the common femoral vein plays an issue, and therefore we need to take this in our consideration for choosing a stent, especially in this area. And here we now have a new option available below the ligament and in the common femoral vein. This is the first and only existing woven nitinol stent. It's called the Blue Flow venous stent from a German company, Plus Medica. A stent which looks like a wall stent, but it is a nitinol woven stent. And this stent gives a very good opportunity, especially for below the ligament. Together with our colleagues from Zurich, we analyzed within the first 100 patients the efficacy and safety of this stent. And what we did, we performed a propensity score analysis between laser cut nitinol stent and woven nitinol stent, so the Blue Flow venous stent, in terms of patency rate and outcome for the patients. And I just want to briefly show you the primary patency rate for the Blue Flow venous stent below the ligament in the common femoral vein after 17 months here. This was 89.4%. Secondary patency at the 17 months was 100%. And when you compare now, based on the propensity score analysis, the woven stent and laser cut nitinol stent in terms of primary patency rate, you can clearly see there was a significant difference in favor of this woven nitinol stent below the ligament and common femoral vein. So this is the first hint that a woven nitinol stent below the ligament is a very efficient way to treat this area. Just for example here, a patient with an obstruction of the common femoral vein here, and this is the deployment of a Blue Flow venous stent here. It's a pin and pull technique of the stent. The stent is available in size from 10, 12, 14 to 60 millimeter diameter and up to 150 millimeter in length. So you have all the different stent diameters and lengths available to treat all problems. And I would like to finalize with this this patient here with a patient with a chronic obstruction occlusion here in the right groin. Unfortunately, the video is not moving. Maybe the next video is, yeah, now it's moving. You can see here, this is a patient with a chronic occlusion of the common femoral vein here, severe post-thrombotic syndrome. We recanalized this patient here. We penetrated the obstruction and then implanted here the Blue Flow venous stent after balloon angioplasty. And you see a very good in and outflow here with a very good lumen gain after this blue flow venous stent implantation. So let me conclude. We now have a lot of tasty apples on the market. We have a lot of dedicated venous stents. The statement, of course, is clear. As we have now so many venous stents on the market, we should never ever use any longer arterial stent within the iliofemoral tract. The early clinical results are promising. Long-term data are coming, but we definitely need more of them. I think personally, additional thinking, research is necessary to understand the stent performance, especially in terms of kink-resistant fracture rate and so on. And broader adoption and experience will definitely drive additional research and learning. Thank you very much.
That's a great presentation, Michael. And I have a few questions which I would like to ask you. Firstly, to start with the blue flow stent. You said it's got a braided structure. And the last braided structure that we used in this area was wall stents. And how different it is from wall stent, and if wall stents can get fracture in the same area, what prevents blue flow from getting fractures?
So based on the initial experience and analysis, we did not see any stent fractures for the woven 19-hole stent so far. I would say personally, wall stent fracture below the ligament is not very frequent. It's a kind of colibri. It's very seldom. The problem with the wall stent below the ligament is that radial force of that stent could lead, especially in young ladies, not obese patients, to groin pain, strange feeling in the groin. Therefore, I would say a wall stent, as we have now many more options available, is not the first choice, at least in my center, for venous treatment. We have so many laser cut 19-hole stents. We have now woven 19-hole stents available. Therefore, I would say we have better options nowadays than a wall stent.
And any concerns about jailing the profunda orifice?
Yeah, it's a very good and important question. I would always try to avoid jailing the profunda. Profunda inflow is your insurance. Femoral vein are, especially in PTS patient, usually quite frequently obstructed, post-thrombotic, flows bad. So if the profunda is patent and gives you a good inflow, don't harm the profunda inflow. It is the insurance for patency.
And in your center, do you perform any endovenectomy in that area in conjunction with iliac vein stents?
Yeah, personally not me. I'm just an angiologist, but I have great vascular surgeons here, good friends who do a great job actually in performing sometimes endophlebectomy and helping me out in some situation, especially when I have bad inflow situations on my flight during an intervention. So these kind of patients we usually schedule in our hybrid operation room, and I start with the endovascular approach. And yeah, during the procedure, when you see the flow is bad, the profunda is bad, and you usually have this kind of scar tissue at the inflow point to the femoral vein, I usually call them and say, please help me out here. And usually this helps. And therefore, I would always recommend to have a good vascular surgeon on board to get a perfect outcome of these interventions.
And the other question which I wanted to ask you is the way you described that the whole anatomy of iliofemoral system has got different properties. It requires different kinds of stents in different areas with different properties, including radial force, flexibility. Do you think that the trials which are being done using just one stent for all these different anatomical regions, they serve the purpose well, or there has to be a movement going towards choosing the right stent for the right iliofemoral segment and then analyzing the data? Because that would be a more ideal situation.
Yeah, I definitely agree. We need all-comers registry analyzing, especially these questions. We have highly selected patients within these IDE trials, patients with non-long occlusions, non-long obstructions, easy cases. We need more experience within prospective registries, and therefore I'm always a fan of a parallel all-comers registry. Every patient who is not suitable for an IDE trial or for a certain prospective trial, put these patients in a prospective registry, analyze these patients, especially the very complex patient, and also patients with IVC involvement. There are no trials, so far as I know, which analyze patients with IVC involvement. Yeah, and there are so many of them, and we do not have data for these patients. We do not even have a good stent for these patients. So we definitely need also to find solutions here.
And I'm sure you must be getting patients who've got their contralateral iliac vein covered during iliac vein stenting done elsewhere, and coming with contralateral iliac vein obstruction. How do you manage those patients?
Yeah, of course, we see these patients. We see these patients with reocclusions, of course, and patients with contralateral DVT or associated DVT. So our principle is to do a bilateral approach in these patients, perform thrombectomy using devices like Pmax device or Jedi Device, whatever. It depends on the material we find within. And then usually, and this is something which changed in our practice during the recent past, is that we end up with a parallel stenting from the IVC in both iliacs, performing a double barrel stenting. I personally believe, I can't really prove it, it's just based on our own experience, that this technique of double barrel stenting might be the best option in terms of patency, especially for these patients. So whenever a patient coming up with these reocclusion, restenosis, contralateral DVT, we are very open for double barrel stenting then.
And patients who come in with in-stent stenosis or stent occlusions, do you look at what is causing the stent occlusion in terms of IVUS estimation of wall characteristics, and what do you find, and how do you tackle stent occlusions? Is there any particular areas which you are really concerned which cause stent occlusion more commonly in the iliofemoral segment?
Yeah, very good, important question. Of course, we see these patients, and the first questions we always ask: what did we wrong? What was the reason here that this stent reoccluded? And the first reason is usually bad inflow. So we did a mistake in terms of analysis of inflow analysis. So therefore, it is always important to learn about inflow. So also for the second redo, third redo, learn about inflow. I personally believe, and we'll publish these data actually quite soon, that you need to have at least 30 centimeters per second flow, either within the femoral vein, profunda, or both of them, to really keep the patency. But no data are available yet so far. Other problems which might occur, which might be a reason for restenosis, rethrombosis, are outflow situations. Unfortunately, I sometimes see patients where the proximal end of the stent ends below the compression within the venous iliac area, the nipple area, meaning that usually IVUS was not used during these interventions. So it's really important to define landing zone so that you create good outflow and definitely inflow. But yes, definitely you always should check what caused the restenosis or what might be the reason for restenosis. And then you can decide, do we go for AV fistula? Do we go for endophlebectomy to improve flow? Do we have to extend? the stent more proximal, more distal? So this needs to be answered before you go for the second intervention.
And do you see a role for endovascular biopsy of in-stent stenosis tissue and look at what really caused it?
Yeah, that's very interesting. Actually, Steve Black did a very interesting analysis here. He captured some of this material with the Hawk system. So he analyzed in-stent restenosis material. And the very interesting thing is that he found a proliferative material like an arterial in-stent restenosis within these stents. So that means, do we need to talk about drug-coated devices to prevent restenosis?
Yeah, that's what one of the audience asked us, whether you need a DES.
And actually, this is a study. This is the Arnsberg DCB post study. This is now analyzing this question. So we are at the moment treating all patients with restenosis or reocclusion with DCBs, just to learn if we can improve patency rates with this approach. Unfortunately, there's a limitation of sizes for the DCBs. So the largest one is 12 millimeter at the moment. So this is definitely something for more the distal part. But what we do in the proximal part before we go for standard balloon angioplasty, we infiltrate this area with a 12 millimeter balloon and then go for 1460 millimeter balloon angioplasty. I don't know if this really helps. This is just an hypothesis. We do not have any data so far. We recently started with this prospective investigator-initiated trial. Maybe we have an answer in 1-2 years.
There's a technical question I want to ask you. Do you do all your stents on a stiff wire or on a floppy or a stiff glide wire? And does that alter the measurements when you want to look at how much the vein has been deformed by these by the stiff wire?
Yeah. Of course, a stiff wire gives you a long vein, without curves. Clearly, this is absolutely clear. But to deploy a stent on a floppy wire, I would definitely not recommend. This could lead to a foreshortening of the stent and cause a lot of problems. I definitely recommend to use a very stiff support wire, whatever you have on shelf. Definitely not a floppy wire for stent implantation. If you want to analyze the iliofemoral tract with IVUS, then of course you can use a floppy wire, Terumi floppy wire, just to learn about kinkings and impact from outside. Of course, that would be the way.
If you use two stiff wires, don't you think that the more you modify the vein tortuosity, the more remodeling will happen, and that could be a cause for restenosis?
Maybe. This is an hypothesis. So a lot of questions our next generation need to answer.
Yeah. So what do you do when you've done an iliac vein stent and already you've taken care of superficial vein incompetence and still the patient's ulcer doesn't heal? How do you approach that?
The reason
I have a few patients and we try and investigate more. And so what has been your experience in your registry?
Actually, then I go for biopsy. Are there other reasons for non-healing? Are there other reasons which cause this ulceration? And sometimes we find very interesting things here. So biopsy is definitely something I would always recommend if an ulcer is not healing even after reflux treatment, obstruction treatment, arterial treatment. Then I would definitely at one point go for biopsy. And sometimes we unfortunately find carcinoma, metastasis or whatever.
And one of the audience asked us, how do you protect against pulmonary embolism during iliofemoral and infrainguinal, DVT? It's not a problem in chronic, but do you have any protection? Because the earlier trials on thrombolysis showed that IVC filter may not be the protective element as we thought before. So is that still the thinking? And do you still do the interventions without any IVC filter?
Yes. I'm not sure if we even have still a standard filter here. I'm not sure. I need to ask my staff, actually. The only thing what we sometimes use in patients who have these kind of floating thrombus from the iliacs into the IVC, we use the Captorex filter from Staub Medical, which is a transjugular brought-in filter system, which look like a basket which you bring in transjugular just above the thrombi temporarily and take it out after the intervention. This
and the clot retriever also does the same, isn't it?
Yeah, correct.
Yeah.
But no, I definitely don't see any value of standard IVC filters now and in the future.
Okay, so we've had a very good discussion on various aspects of iliac vein interventions, both for acute as well as for chronic. Just to wrap up, if you were given a crystal ball to predict the future of venous interventions, what do you see?
I see millions of patients actually still running around suffering from post-thrombotic syndrome who are not treated because awareness is bad. And I definitely suggest that we improve awareness, improve the treatment for these patients, educate more younger interventionalists that these patients do not need to suffer any longer. And I personally believe that we are at this moment are not doing a good job, especially in terms of awareness, and we have to improve that.
Thank you very much, Michael. It has been really a pleasure and privilege to be with you, and great presentations. Unfortunately, that's all we have time for today. We hope that our audience found it both informative as well as engaging. And thank you, Michael, and thanks for our Radcliffe Vascular staff who made it possible. So here it is, wrapping up from Radcliffe Vascular. Thank you very much, all.
Thank you very much. Goodbye.